Imagine going in for a routine reconstructive surgery, like to fix a sagging bladder. Your doctor tells you the procedure will essentially, tighten things up down there.
Which is a phrase we hear all the time.
Right. And culturally, we hear that word tight, and we automatically think of an upgrade. We assume it means enhanced sensation, better sexual function, maybe a return to a more youthful state.
Yeah, people expect things to feel better.
Exactly. But then weeks later, when you're fully healed, you realize the exact opposite has happened. The sensation is just, well, entirely gone, replaced by this rigid, restrictive wall, or even worse, severe pain.
It is a really jarring reality.
Mm-hmm.
And it completely flips our cultural narrative on its head. I mean, we tend to assume tightness is just a simple metric of diameter. Like if it's narrower, it's tighter.
Yeah, that's the logic.
Right. But medically, anatomically, and neurologically, tightness is just vastly more complex than that.
Well, welcome to the deep dive. And a special welcome to you, the learner, whether you're actively prepping for a medical consultation, supporting a partner through recovery, or you're just insanely curious about how the human body actually works beneath the surface.
We are thrilled to have you here.
We really are.
Today, we are taking a crucial, empowering look into an often taboo subject, giving you the exact vocabulary you need to understand pelvic health without, drowning in all the medical jargon.
Yeah, our goal today is to really look at the mechanical reality of what happens when a vagina is surgically shortened. We've got a whole stack of medical guidelines here, including from NICE and the RCIG, along with surgical consent forms and clinical trial data.
It's a lot of material.
It is. And we're going to use it to demystify this paradox of perceived tightness versus functional elasticity and really explore the incredibly delicate balancing act surgeons have to perform to restore a patient's structural anatomy without destroying their sensory function. Okay, let's unpack this. Because before we can understand why the sensation changes or disappears entirely, we kind of have to understand the architectural changes happening in the operating room. Like, why do these reconstructive surgeries alter the size and shape of the vagina in the first place?
Well, to understand the surgical effects, we first have to understand the collapse. We're primarily talking about procedures that correct pelvic organ prolapse, or POP.
Right.
If you imagine the pelvic floor, it's essentially a dynamic hammock made of muscles and connective tissues.
And it's holding everything up.
Exactly. Its entire job is to hold up your bladder, your uterus, and your rectum against the constant force of gravity.
But due to things like childbirth or aging or just chronic pressure over decades, that hammock phrase...
It weakens, it stretches, and sometimes it actually tears. And when the support goes, gravity just takes over.
Yeah.
Organs literally start to fall.
Which sounds terrifying.
It's incredibly disruptive. I mean, if the bladder sags and bulges forward into the front wall of the vagina, that's called a cystocele. If the rectum bulges into the back wall, that's a rectocele.
Yeah.
Patients describe this feeling of something literally falling out of them.
Wow.
Along with severe urinary leaks, recurrent infections, and just chronic dragging pain.
So, to fix this structural collapse, surgeons perform what's called a vaginal wall repair. And looking through the surgical guidelines in our stack today, the mechanics of this are pretty fascinating.
They really are.
The surgeon goes in, finds that overstretched, weakened connective tissue between the organs, and they fold it over. They plicate the fascia, stitching it together to pull that sagging bladder or rectum back up into its proper place.
Right, they have to restore the support.
But the sources point out a really fundamental physical reality here. To achieve that lift, the surgeon often has to trim away a portion of the vaginal wall itself, just to get rid of the excess stretched out tissue.
Because you can't just push a heavy organ back into place and hope it stays. You have to fundamentally alter the scaffolding underneath it.
Right.
When a surgeon shortens that plate of connective tissue to hold the bladder up, the inevitable byproduct is a shortened vaginal canal.
It makes perfect sense if you think about tailoring a piece of clothing.
Oh, that's a good way to look at it.
Like if you have a dress where the fabric has been severely stretched out and is bagging at the seams, you take the fabric in to fix the structural integrity of the garment. But by doing that, you inherently change the overall fit and the dimensions of that dress. You can't remove fabric and keep the exact same size.
That is exactly what's happening. The surgeon is making a highly calculated trade-off. To achieve functional stability, to stop the bladder from leaking every time the patient coughs or sneezes, which these anterior wall repairs do successfully about 66% of the time. By the way, they must reestablish tension.
They have to pull things taut.
They do.
And the data shows it's not just prolapse repairs altering the architecture. We see the same dimensional shifts with hysterectomies.
Yes, absolutely.
When the uterus and the cervix are removed, the surgeon has to close the hole left at the top of the vaginal canal. They suture it shut, creating what is referred to in the texts as a vaginal cuff.
And creating that cuff completely changes the support dynamics of the entire pelvis. I mean, the natural suspensory ligaments that held the cervix up and allowed it to move are either gone or permanently altered.
So it's locked down.
Pretty much. The canal is now capped off with a stitched line of scar tissue, which can make the vagina both physically shorter and significantly less elastic at the very top.
So the body was structurally failing, and the surgical fix requires cutting away tissue, adding tension, and capping things off. We know the canal gets shorter and narrower, but this is where I need to stop you.
Okay, what is it?
Because my brain is snagging on a massive contradiction in these medical files.
Let's hear it.
Here's where it gets really interesting. If you look at the elective aesthetic side of medicine, you have surgeries like vaginoplasty.
Right.
In those procedures, surgeons deliberately tighten the muscles and remove excess lining specifically to improve vaginal tone, to increase sexual friction and sensation. People pay a premium for that.
They do.
But if you look at the British Society of Urogynecology consent forms for the reconstructive wall repairs we just talked about, it explicitly warns patients that post-surgery, they might feel, quote, too short or too tight.
Yeah.
And that sensation during intercourse may be severely reduced or orgasms might be less intense. So if an aesthetic surgeon cuts away tissue to increase sensation, why does a reconstructive surgeon cutting away tissue kill the sensation? Aren't they doing the exact same thing?
It looks similar on paper, sure, but mechanically, they're entirely different environments.
How so?
The difference comes down to the profound gap between muscular tone and structural tension.
Okay, explain that.
Well, in an aesthetic vaginoplasty, the goal is typically to restore the dynamic, responsive capability of the vaginal muscles. And healthy muscle yields. It stretches, it responds to blood flow, it adapts to movement. It has tone, yes, but it's not a brick wall.
It's active and dynamic.
Precisely. But when we talk about reconstructive shortening to hold up a prolapse or stitching a vaginal cuff, we're dealing with scar tissue and load-bearing tension.
Load-bearing.
Right. The vagina requires adequate length, profound elasticity, and a healthy lining to function comfortably during intimacy. When you shorten the connective tissue to hold up a heavy, sagging bladder, you are creating a tight, taut structural barrier. It's restricted mobility.
Oh, I think I'm getting it. So perceived tightness isn't actually about diameter at all.
No, not really.
It's not just about how wide or narrow the canal is. It's about the tissue's ability to accommodate depth and movement. If a reconstructive surgery makes the canal too short or the top of it too rigid with a cuff, the tightness a patient feels isn't a healthy, responsive grip. It's a physical limitation. It's the tissue flat out refusing to yield.
And that lack of yielding has a cascading effect on nerve endings and blood flow. I mean, sexual arousal fundamentally requires tissue engorgement and expansion.
Right.
If the vaginal tissue is pinned down tightly with sutures to prevent a bladder from falling, it just can't expand normally. That mechanical restriction is what leads to the reported loss of sensation or intensity. The vagina's primary job in that moment is acting as a rigid, load-bearing wall, which completely compromises its sensory function.
But what happens when that necessary tension turns into like a permanent roadblock? I mean, there has to be a line between a surgically altered area that just feels a bit stiff and a full-blown medical complication where the body's healing process actually freezes the tissue in place.
Oh, there is a line. And that boundary is crossed when we look at a condition called vaginal stenosis.
Stenosis.
Right. Specifically, iatrogenic vaginal constriction. That's what happens when aggressive scar tissue makes the vagina significantly narrower and shorter than the surgeon even intended.
The clinical descriptions of the scar tissue are brutal. I was reading through the sources, and unlike normal, healthy vaginal mucosa, scar tissue just doesn't stretch. It lacks flexibility entirely.
It does?
So when something enters the vagina, whether that's during intimacy, a routine pelvic exam, or even just inserting a tampon, it's rubbing against stiff, unforgiving tissue rather than pushing against soft, flexible walls.
And the immediate consequence of that friction is dyspareunia, which is the clinical term for painful sex. And we are not talking about mild discomfort that you can just ignore.
Right, this is severe.
The long-term data tracking prolapse surgeries shows that severe de novo or new-onset dyspareunia is a major risk. In one 5-year follow-up of a specific prolapse repair, laparoscopic sacrocolpopexy. Nearly a quarter of sexually active women reported severe pain that simply wasn't there before the surgery.
Nearly 24% 60 months later. That is a staggering shadow to cast over a successful structural repair.
It really is.
And the sources note this extreme scarring is also incredibly common after pelvic radiation therapy for cancer, right? Where the radiation damages the tissue and causes severe constriction.
Yes, exactly.
But this is also where the research offers a massive breakthrough. Because the question is, how do we fix tissue that has frozen up like that?
Well, the traditional approach has always been passive stretching.
Right. Doctors would prescribe passive vaginal dilators, basically these smooth, graded cylinders. The patient is instructed to insert them and just let them sit there to stretch the tissue out.
But a fascinating clinical trial recently challenged that standard. They took a group of women suffering from severe vaginal stenosis and pain and split them up.
Okay.
One group used those traditional passive dilators. Yeah. The other group received a treatment called oncological perineal massage, or MPO.
Which is much more active, right?
Right. Yes. This is a highly active, dynamic mobilization and stretching of the tissue performed by a specialized physical therapist combined with at-home exercises.
The contrast in the results completely upends how we usually think about post-op recovery. Over 10 weeks, they measured the patient's vaginal pain on a visual scale from 0 to 10. The active massage group started with a median pain score of 8.5.
Which is very high.
Very high. But by the end of the 6-month follow-up, their median pain had dropped to 0.
A total eradication of the pain.
And the passive dilator group, their pain only dropped from an 8 to a 5.
Still pretty painful.
Yeah. But the structural healing is what really caught my eye in the data. At 6 months, 16 out of the 18 patients in the active massage group were completely free of stenosis complications.
That's incredible.
In the passive stretching group, only 3 out of 17 recovered. So active massage virtually cured the stricture in the vast majority of patients, while passive stretching barely made a dent.
It's a huge difference.
Why? I mean, if both methods are applying physical stretch to the tissue, why does the active massage work so much better?
It comes down to how scar tissue behaves at a cellular level. Active manual manipulation does things that static stretching simply cannot do. First, the massage significantly enhances local microcirculation. It brings fresh blood, oxygen, and nutrients directly to the damaged tissue without causing harmful inflammation.
So think of passive stretching, like pulling on a cold, hardened rubber band. It resists, it causes friction, and it might even cause micro tears that lead to more scarring.
Exactly.
But active massage is like warming that rubber band up in your hands, kneading it until the natural elasticity returns.
That is a perfect analogy,
Right.
because the dynamic stretching is literally stimulating the remodeling of collagen and elastin fibers. It breaks up the rigid, cross-linked fibrosis of the scar and forces the body to lay down new, pliable fibers.
Wow.
It proves that overcoming pathological tightness requires dynamic healing. You can't just passively force a cold scar to stretch and expect it to behave like healthy muscle again.
And reading through the trial, there's a profound psychological unwinding that happens too. The interactive nature of the massage helped these patients regain awareness of their pelvic region without the association of sharp pain.
Right, the brain-body connection.
Exactly. It lowered their anxiety, which stopped their pelvic floor muscles from involuntarily guarding and clamping down.
It's a brilliant evolution in physical therapy. But it also highlights a frustrating reality. This is a massive burden placed on the patient after the surgery is already done.
Which begs the question. If we know this tissue can freeze up so badly, and we know that surgical shortening destroys sensation, why are we letting it happen in the first place? Like, what are surgeons actually doing at the operating table to prevent this?
Well, the surgical field is acutely aware of this, and they are getting much more sophisticated with their geometry.
Geometry.
Yeah, the primary goal of a pelvic reconstruction is no longer just fix the bulge. The modern mandate is fix the bulge while preserving total vaginal length.
And the data gives us a really clear picture of how they're doing that, especially when treating vaginal vault prolapse, which is when the very top of the vagina collapses downward.
Right.
Surgeons essentially have 2 routes to fix it. They can go in through the abdomen, like with a sacrocolpopexy, or they can go in entirely through the vagina, like a sacrospinous fixation.
Let's look at the gold standard clinical guidelines from the UK on this. The data clearly shows that the abdominal approach results in a significantly longer vagina compared to the vaginal approach.
So essentially, the abdominal approach is like pulling a collapsed tent pole up from the very top, attaching it to a high anchor point like the sacrum bone, and keeping the whole tent tall and spacious.
Yes.
But the vaginal approach tethers the top of the tent to a ligament much lower and deeper inside the pelvis, which inherently drags the roof down and
Yeah.
pulls it off center.
And that structural difference translates directly into sensory outcomes. Because the abdominal approach maintains that long anatomical axis. The data shows it cuts the risk of painful postoperative sex by more than half compared to the vaginal procedures. We're talking a risk ratio of 0.39.
That's massive. But the surgical engineering doesn't stop at just picking a different entry point. These surgeons are literally down in the weeds, debating the exact geometry of how they stitch the tissue.
Oh, the cuff closure trial.
Yes. There is a fascinating clinical trial in our stack investigating how to close the vaginal cuff after a hysterectomy. Do you stitch it side to side horizontally, or do you stitch it top to bottom vertically?
It sounds like such a minor detail, but it's a perfect illustration of how every millimeter matters in these surgeries.
Right.
The trial hypothesizes that horizontal closure, suturing right to left, might better maintain a natural width and preserve length in the horizontal plane. Meanwhile, vertical closure might reduce tissue tension and provide better upward support for the pelvic structures.
So they're scientifically measuring the directional pull of the thread just to save the patient's functional elasticity.
Exactly.
So what does this all mean? If you, the listener, are facing a prolapse repair or a hysterectomy tomorrow, and you're terrified of waking up with a shortened, painful vaginal canal, how do you navigate these choices?
Well, the big takeaway from all of these sources is that the era of the one-size-fits-all pelvic surgery is definitively over.
Yeah.
Personalized surgical planning is an absolute necessity now.
Because everyone's anatomy is different.
Right. For instance, the guidelines explicitly state that a vaginal approach, which is often faster, cheaper, and has a much quicker recovery time, might be totally appropriate for an older woman who is no longer sexually active and just wants to avoid abdominal surgery.
But that same quick procedure is flagged as completely inappropriate for a younger, active woman.
No.
Or a woman who already has a naturally short vaginal length.
Exactly. You do not want to take a short canal and intentionally make it shorter and tighter.
The surgeon really has to weigh the mechanical repair against the patient's baseline anatomy and their future functional goals. Preserving length requires a specific, often more complex surgical strategy.
And patients need to understand that their sensory function is just as important as their structural repair.
This has been incredibly illuminating. I mean, we started with this paradox. Why does surgically tightening a vagina sometimes ruin sensation and cause severe pain? And the core aha moment here is that vaginal tightness is not a simple measurement of size.
No, it's not.
It's not just about being narrow. It is a highly complex, dynamic interplay of muscular tone, nerve function, blood flow, and structural elasticity.
When reconstructive surgery trims away tissue or pulls the fascia taut to eliminate a painful prolapse, it fundamentally alters that pelvic architecture. It trades dynamic, yielding flexibility for a static, load-bearing wall.
And for you listening, armed with the insights from this deep dive, you now have the exact vocabulary you need. If you or a loved one ever face pelvic surgery, you don't just have to nod along when a doctor says they're going to repair the wall.
You can ask specific questions.
Exactly. You can ask them, what is your strategy for preserving total vaginal length? Or what are the specific risks of stenosis with this approach? And can we prescribe proactive physical therapy? Are you doing a horizontal or vertical cuff closure, and why?
You're now equipped to advocate for your functional future, not just your structural repair.
Exactly.
But, as we step back from the mechanics of surgical repair, there is one fascinating nugget buried deep in the clinical texts that kind of challenges everything we assume about standard anatomy.
Oh, what's that?
Well, we've spent this entire discussion analyzing the millimeter by millimeter alterations of a single vaginal canal. But the medical texts briefly note that some women are actually born with duplications of the vaginal canal.
Wait, duplications? Like 2 of them?
Yes. Congenital anomalies where a tissue partition or a septum runs the entire length of the vagina, effectively creating 2 distinct canals side by side.
That is wild.
And sometimes one of those canals can be obstructed, or the septum bulges near the entrance. And incredibly, doctors unfamiliar with the anomaly will completely misdiagnose that bulging septum as a prolapsed bladder.
Oh, no way.
Just imagine the sheer surgical complexity of navigating perceived tightness, sensation, and structural repair when you are unknowingly dealing with a duplicated anatomy.
It's an entirely different dimension of human biology.
It is a profound reminder that the human body is rarely a standard textbook diagram. It's incredibly varied, and there's always another layer of complexity to explore.
Something fascinating for you to ponder on your own. So the next time you hear a term like tightening, remember, the body is not a machine with binary settings. It's a living, breathing ecosystem where every structural shift creates a profound sensory ripple. Thanks for taking the deep dive with us.